All right. Welcome everybody. I'm here with Farouc, Jaffer, moderating this session on new devices, so this should be fun. We always like to see what new toys we get to play with. We got an amazing panel. Perwaz, Meraj, Arasi, Maran, Rick, Shunk. Who's this guy? Cal Alaswad. And Bernardo Cortese. Hi. Amir. Hi. Nice to meet you. So we'll start the session off with Michael Magali, who's going to be talking about drug-coated balloons for ISR. It's like you're a little...
I'll take one of those. All right. Awesome. Thank you to the organizers. Such a privilege to be here. And it's funny, this called new devices, though drug-coated balloons have been there for so long. So today I'm talking about specific use of drug-coated balloons in ISR. And I'll start quickly by running over. It's like everyone knows now, drug-coated balloons have been in the US for quite some time, been outside the US for so long. It basically depends on delivering a very high dose of the drug, mostly paclitaxel. There are some sirolimus drug-coated balloons right now. It depends on fast release. You inflate the balloon. It's mounted on an excipient. It should go into the media, which is the source of smooth muscle cells. And then you come out, you leave no implant, which is great. That's all what we like about it, not leaving any metal behind. Great other thing about drug-coated balloons is that it can cause late lumen gain, especially in vessels that are small, from 1 to 2.5, which don't do very well with stents. These vessels, you put drug-coated balloons, you gain some lumen after 3-6 months. So the question is, we're in a room full of great operators who all use IVIS. We expand stents as much as we can. Do we still have to worry about DES ISR in the current era? And the answer is, in my opinion, yes. And this is for a couple of reasons. Number one is actually us. No matter what we do, there will be these lesions. There will be this calcified nodule that no matter what we hit it with, it will not expand. There will be that stent that no matter what we do for it, it still recoils. So it is still a problem. And then, of course, there are non-modifiable factors like the patients we treat, diabetes, small vessels, long lesions, 2 stent strategies, and of course the mother of all bombs, calcification. There's a great study by Dr. Stone showing that even second-generation drug-eluting stents still have a target lesion failure of 5% in 1 year. And then if you do a landmark analysis up to 5 years, 7.7%. So about 2 to 2.5% TLF rate per DS when we place it in. So it is a problem. So in order to understand ISR, this registry is a great registry from France, about 300 patients with ISR. They were evaluated by OCT, and then they were treated, and then OCT was done again. And as you see here, most important thing we need to understand about ISR is what is the mechanism, what is the histopathology of this. And it starts in panel A with neointimal hyperplasia, and you have the intima, it starts to become thicker and thicker, and then it becomes a little bit heterogeneous when it starts to deteriorate. This is panel B. Then in panel D, this is neoatherosclerosis, when it starts actually degenerate and starts to have macrophage foam plaque. And then panel E, it becomes calcified. It's called calcified neoatherosclerosis. And of course, the worst of them all is a calcified nodule within the stents. And if we in panel C, it's just 2 stents. And in that study, about 43% of ISR was due to underexpansion, huge number, and about 30% happened due to multiple stent layers. And in order for us to understand the distribution of this, it all starts with, of course, neointimal hyperplasia, then becomes heterogeneous. And the more time from the index procedure till the ISR, the more we go towards the tougher lesions with calcified neoatherosclerosis. So the funny thing about these cases, when they were treated by great operators, still only 52% of them achieved good expansion, good MSA. And that shows us that ISR is not that benign, it's not that very easy to treat, it's not a one-size-fits-all, let's put a drug-coated balloon or another DS and gets done. A lot of these patients do not get to the adequate MSA that we need, and about 16% of them didn't even get to expansion or MSA. And MSA is very important because in that specific study, when they achieved MSA more than 4.5 millimeters squared, it had great outcomes. When it's less than that, it's bad. And also in that specific study, which is the next thing I want to deliver here, is that when these patients were treated with DES, they had much better outcomes. All right, so is that not a randomized trial? Is there evidence from randomized trials? And actually there is. This is the Daedalus meta-analysis from 10 RCTs comparing drug-eluting stent versus drug-coated balloons in ISR. And in that specific study, DES was significantly more superior than DCB, 16% TLR at 3 years versus 12%. And this definitely led to the recommendation that DES is class 1 indication right now over drug-coated balloons for ISR. So am I here to just say don't use the drug-coated balloons for ISR, and that's not what I want to say. You just want to look at, is that fair? Is that class 1 indication fair? And is it granular enough? And one thing about DS, we talked about drug-coated balloon, but DS has a lot of advantages. It has this mechanical support that prevents recoil, that if there is any mechanical issue, it supports it. That mechanical support is very important. And the second other thing is that the drug delivery, it's slow, it's based on strut, and it's persistent. If for any reason when you deliver drug-coated balloon, if there is any technical error and you cannot deliver the drug to the media, that's gone. But when you have a DS in place, you have a slow and release drug, and that's why maybe it is superior in some kinds of ISR. But on the other hand, let's talk about the other case. Is it fair for drug-eluting stent to be just class 1 indication? And the first thing we have to look at the Daedalus study, and there are a few points here that only 2 studies reported outcomes at 3 years. These are very small number of patients. And of course, these outcomes were driven by poor outcomes between 6 months and 1 year. So something happened within that first year that made the drug-eluting stent better. Is it technical issues? Is it technical errors? Is there a mechanical thing that was missed? But then when you do a landmark analysis at 1 year to 3 years, it was not that bad. It was both did actually the same. That leads us to the second point, that we lack granular data in these current studies. These mechanisms I saw, it makes a big difference in our decision of the treatment. Because if we have mechanical issues like a stent fracture, geographic miss, or when you inflate the balloon, you have dissection grade C within the new atherosclerosis, there is no drug-coated balloon that will fix that. you will need to put a scaffold in there. And of course, the second thing is the poor penetration. Again, the main mechanism when the drug is working from the drug-coated balloon is that you deliver it to the media, deliver it to where smooth muscle cells are. And if you have very thick new intima that you didn't ablate, calcium that you didn't modify, multiple stent layers, it will not work. And that leads me to the third point, which is we have to look beyond the first event. TLR was, way higher in drug-coated balloons than drug-eluting stents, but let me ask all the interventional here. Would you rather treat those 12% TLR in the DS group or the 16% TLR in the DCB group? And we look at histology. I mean, the more stents we have, the tougher and tougher it gets. And for me personally, I'd rather take that patient who had DS, treated with drug-coated balloon, later on came in with for TLR for any reason. It's way easier to treat. We have a lot more options, as we say in the PAD world. We have a lot more options if we have less stents in place. So that also brings us to the next point. This is a great study from the Japanese registry looking at 300 patients I saw treated with drug-coated balloons. And they compared 1 stent layer, 2 stent layers, and 3 or more stent layers. And if you look at just the colors and numbers, it's dramatic. When you have 1 or 2 stent layers, your risk of TLR is about 15% in 1 year. But when it becomes 3 or more, we are talking about 41% TLR rate. So basically putting in a 3rd stent in a coronary artery is like giving them cancer, and we should avoid it by all means. And I think, in my opinion, the best way to avoid putting in a 3rd layer stent is to avoid putting in the 2nd layer stent. Moving on quickly, this is an algorithm that is proposed by Restro Registry authors. Basically, I mean, it is very simple. You do OCT. If you find an expansion, you treat it. And then if you have multiple stent layers, just put a drug-coated balloon. If you have new atherosclerosis, then they prefer using drug-eluting stent over the balloon. Still, this has to be prospectively evaluated, but this is one of the proposed algorithm and how to use it. And finally, take home, yeah, drug-eluting stent is class 1 indication for ISR, but there's a lot of granularity here that we have to look at. We have to do imaging. If there is a mechanical issue, you have to fix it. If we have to put in a stent because of a mechanical issue, that is the right answer. Then we have to look at mechanisms. I am a primarily IVUS user, not an OCT user, and I know it's going to be very tough for us to evaluate this, but the main point is, common sense is, if we can ablate this, if we can treat this, if we have very good expansion and not a lot of barriers to deliver the drug to where we want it to be, then maybe drug-coated balloon would be best. If not, maybe drug-eluting stent would be best. But by any means, we have to avoid putting in a third layer stent no matter what. Well, thank you.
Thank you, Michael. Very nice presentation. I agree with all of it, but let me be the devil's advocate. You know, I love DCB. You know that. We did a few publications together. But okay, if the TLR rate with drug-eluting stent in the ISR setting is below 10%, if it's like 6 or 7%, like the Lumion 4 sub-study showed at 1 year. Do you still think that we should go on using DCB? Because in the studies that you showed, the studies that were pulled up for a Daedalus, were studies done between 2008 and 2014. At that time, the penetration of intravascular imaging for ISR was so low. It was like less than 10%. Illumin 4 is all of it. And the TLR with DS for ISR setting went down further to 6 to 7% at 1 year. So how can you, where do you see the role of DCB in this setting?
Well, great question. You can't. It's very tough to fight against such a great plethora of data in a class 1 indication. But what I would say is, again, we still lack granular data. We don't know if the 6%, I mean, maybe a subset of these patients that were treated with drug-eluting stent would have done as well with drug-coated balloons if we have treated all mechanical issues, and we know there is no mechanical issue to be evaluated here. And again, my other point here is, if we avoid putting in a second layer stent, we would probably not need to put in a third layer stent. And again, it is very tough at this point with the current data to say, hey, let's use drug-coated balloons on everyone or drug-eluting stent on everybody. But what I would say is, if we can guarantee that we can deliver the drug and we have no mechanical issue, I myself would rather use a drug-coated balloon, because if that patient comes back, I have to think ahead, how am I going to treat him after? If I put a drug-eluting stent now and I got him come back 6, 7, 8%, 10% of the time, I am almost out of options. That's what I'm thinking.
This is a great presentation. We still have a couple more minutes for discussion. Maybe we could hear from some of our panelists as well. One of I think the kind of binary decisions one has to make is in single stent layer ISR. Are you going to put that second stent in, or are you going to go to DCB? We can go down the panel, but Rick, would you like to comment? How do you make that decision? What are the factors that you're thinking about?
Sure, yeah, I think, Michael, you did a great job of outlining that. For me, you have to identify what is the problem, and I think the intravascular imaging is absolutely key. And I'm just curious how, when you see that the main problem is not that the stent never expanded properly or there's a big chunk of calcium, but there's just a lot of intimal hyperplasia. I'm not sure if DCB is the right approach there. Sometimes scaffolding is needed. I know you want to avoid the second stent, but how do you individualize? I know as a strategy, we don't want to put a second stent. We don't want to put a third stent. How do you individualize based on the IVUS, whether you're going to tackle the intimal hyperplastic problem mostly, or the lack of expansion problem, maybe being more aggressive OPN balloons, maybe other things, and for an individual patient. Can you comment on that a little bit?
Well, individual, I mean, again, we just got the drug-coated balloons, right? It's like me myself, I haven't used it for so long. So the answer was always like, expand the stent, do as much as you can. And even before drug-coated balloons, some of those were left alone, even with balloon angioplasty, not the second-layer stent. But if we expand it completely, and we have good expansion, and you have a thick, intimate layer that you could break through and create some dissections in it, again, I myself would go to a drug-coated balloon right now rather than putting another layer stent, just because I want to think ahead, and I don't want to, have this patient come back, and then I'm out of options.
Yeah.
I think I would say that it's a great question. How do you, based on the mechanism, if it is an underexpanded stent, then the answer becomes much more clearer. Crack the calcium to the best of your ability. But neointimal hyperplasia is the problem, I think, best treated with a drug-coated balloon, because it is the anti-neoplastic effect of extra cell growth, etc. So if your treatment modalities, whether it is rotational atherectomy or laser atherectomy or whatever ablative procedures you do, and your NC balloon expansion, does it give you a stent-like result? And then you paint that new stent with the drug-coated balloon, then you have achieved it. But with all your balloons and everything, there's still a thick layer of neointimal hyperplasia. In that place, putting the drug-coated balloon may not give you the best long-term.
Can I, sorry, Ken. So I treat coronary arteries like a dermatologist nowadays. It's like dermatologist, the patient never cure and never dies, and they keep coming back. So basically, if you treat it, you should plan on following the patient closely. And I use a drug-coated balloon. I'm advocating for actually drug-coated balloon strategy. And if that failed, I think and it needed a stent, we can stent it later. And I've seen our colleagues in Europe doing that, and with a great success.
Why don't we go on to the next lecture? Thank you so much, Michael.
One thing for the people in the back, there's still chairs on the other side, so feel free to walk through, and there's a bunch of chairs unless you want to stand more. And then any questions, please, here's your hand up, and we'll bring a microphone to you. There's also a microphone in the front of the room. So thank you, guys.
Great. Okay, we can head over to our next talk, the role of drug-coated balloons in native coronary vessels. Dr. Cortese, thanks so much.
Thank you. Thank you. All right, so native vessel disease. So I'm trying to convince you that this is a potential. It's already present. It's a potential development of how we are treating coronary disease patients in the US. Now DCB are being used for 20% with a high variability between the centers of all coronary disease in Europe and even more in Asia. In China and in Japan, they use DCB in more than 40% of PCIs, and our Chinese and Japanese colleagues are highly experienced, are not crazy. But I admit that we still need some data. I'm starting with a case here. So this is a case that I did during one of my proctorships in Europe. So this lady, she was a young lady with this proxial AD, diffuse disease. Then we have this ramus in a trifurcation. So I don't decide my ultimate therapy until I prepare the lesion. Yesterday, that was my key message. But here, I would try all of my best to avoid stenting for these reasons. There is a big discrepancy between the left main and the proxial AD, and there's a trifurcation. So if we can avoid stenting here, distorting it too much, I think we do a good job. So what we did here, we predilated the lesion. We predilated the lesion of the LAD. We use a scoring balloon for the proxial LAD, and then we use a semi-compliant balloon in the ramus, and then we use a DCB in the ramus. And then we assessed the result. There was this dissection here, which is not flow limiting. So this is, I would say, a benign dissection to be left for DCB. And then we started using DCB. We use a DCB. In this case, it was limus DCB in a ramus. Then we use DCB in the proxial LAD, here in the ostial, in the proxial LAD, and we did POBA in the distal LAD because we didn't want to spend too much money. And so this is the final result, which is pretty good. There is still the dissection after the DCB use. We took the final angiogram after a few minutes. There is no recoil. The flow is still good, so we stopped. And the colleague sent us the angiographic follow-up after a few months showing that patient was asymptomatic, no acute vessel closure, and this is a normal history. This is not just a case super selected. So if you have these parameters, you stop doing PCI, you're not going to have the patient coming back for acute closure. And this is the result in the LED, which is amazing, prox LED, mid LED. We have some restenosis here where we use POBA. So small vessel disease. Okay, small vessel disease is 50-60% of all our PCIs. Small vessel disease, DCBs, paclitaxel especially, have shown that they are outperforming angiographically drug-eluting stent. Of course, this parameter, late lumen loss, is advantageous for DCB as compared to stents, but this is the data that we have. But on top of this, we learned a lot. So why did it take so much time for DCB, which were marketed in Europe back in 2007, before being used so diffusely? Because we did a lot of mistakes. So this is our study, Piccoletto. We enrolled patients in 2008. We presented data at the EuroPCR 2009, published 2010. Look at the lesion preparation. Nothing, 20-something, 24% if I remember well. So at that time, we didn't know that. And this is the drug-eluting stent arm predilatation. We knew at that time that we had to predilate. And then we got it better and better with all of the other trials, up to one of the latest native vessel disease studies, where predilatation is 100%, and bailout stenting, look at here, bailout stenting is so low because we learned how to predilate. We came back to the POBA era, and we learned how to do that. And then we have some more data, some more mechanistic data, and then I will go delving a little bit more into the clinical data. We have a Piccoletto 6 study, which we presented last year at TCT. These are only experienced centers, native vessel disease, small vessels, again, only experienced centers, which is the angiographic and physiological performance of DCB during angiographic follow-up with the core lab, and which is the difference between paclitaxel and sirolimus. So far in the US, we only have paclitaxel. We will probably have sirolimus soon. So again, this is a small vessel disease study. You can see lesion length is pretty good. It's 24 millimeters. Late lumen loss. Late lumen loss at 6 months is very good. It's overall 0.01, so it's almost negative. It's 0, okay? As compared to stents, which have a late lumen loss in small vessel disease between 0.15 and 0.20. Paclitaxel did actually outperform sirolimus because of a lumen enlargement, but also sirolimus did, I would say, a good job. Lumen enlargement, this is something that you don't have with stents. We have lumen enlargement with drug-coated balloons, mostly with paclitaxel in 55%. In some studies, it's even larger than that. It's up to 70%. And we have it also with limus, 40%. And then what about the physiological performance? This is an angio-derived physiological measures done with the μFR. And you can see that the vessel μFR did not change significantly between end of PCI and during the angiographic follow-up. This is the delta, 0.01 late functional loss, minus 0.01 and 0.03. A little bit better for paclitaxel, but no significance with the limus. Clinical data. So last year, this big study was presented and published on The Lancet. This is a study performed with drug-eluting stent and paclitaxel coated balloons, which is not available in Europe, only in China. And so here, the authors wanted to compare it in a native vessel disease setting, easy lesion setting, to a drug-eluting stent, hypothesizing the non-inferiority. In the overall population, non-inferiority was not met. So in the easy lesion setting, DES did outperform this paclitaxel coated balloon. There is no difference only in the small vessel disease. So in vessels between 2.0 and 3 millimeters, there is no differences in terms of clinical performance at 2-year follow-up. And this year at TCT, we will see the 3-year follow-up of this study. So very interesting data. For a small vessel disease setting, this year we published the Andromeda meta-analysis. I presented it several times, but it's, I think, an important piece to understand which is the performance of paclitaxel-coated balloon in small vessels. So here, vessels are up to 3 millimeters. This is a patient-level meta-analysis with all of the randomized clinical trial investigating DCB with long-term follow-up. Okay, so we wanted to see if at 3 years follow-up or more than 3 years follow-up, there is any clinical difference between drug-eluting stent and DCB. We collected data for 1,500 patients, and this is the primary outcome, which is MACE, which is significantly reduced, MACE, which is significantly reduced as compared to drug-eluting stent during the 3-year follow-up by 25%, so which is a very important information. And if we see the determinants of the primary endpoint MACE, we can see that with DCB, paclitaxel DCB, we have less myocardial infarction, we have less TVR, and we have less vessel thrombosis as compared to drug-eluting stents, with an effect which is mostly evident for the younger patients. So if patients were 67 years of age or less, they had a pronounced effect which is maintained in this forest plot with a P4 interaction which is positive, so it's consistent. The future. So I was telling you, I'm not saying that we should use DCB as the primary therapeutic option. We don't have enough data to say that. Maybe we have now data for small vessels, but not for the overall native vessel disease. There are some studies that are coming up. So some of them are performed by my institution and my foundation. Cardiac is a severely calcified lesions with atherectomy or IVL, which is the role of DCB here. We know that stents do not expand perfectly also if we use atherectomy. Let's see if DCB have a role here. So we collected data, we have a core lab, and we submitted the study to TCT. Another big study is, where is Manos here, is the Piccoletto 10. Piccoletto 10 is a CTO. Okay, CTO study. There is a growing experience and usage of DCB in the CTO setting. We collected data from a lot of experience centers in Europe and some of them in Asia. 860 patients treated with DCB in CTO are being analyzed, and we will analyze, of course, half of them have been treated with drug-eluting stent plus DCB. So in a blended therapy, we will analyze and compare the performance of solo DCB and DES plus DCB in the CTO setting, and we submitted that. Well, I have to submit it to TCT as a late-breaking trial. And then we have Piccoletto 5, which is the bifurcation, but it's a bifurcation with a solo DCB. So we are comparing, it's a randomized study, we are comparing EBC-like, which is provisional stenting, versus full paclitaxel-coated balloon versus full sirolimus-coated balloon. This is a mechanistic study that we provide more information on the role and usage of DCB in this setting, and I'm happy to share that in Romania we enrolled the first patient last week. I'm going to the conclusion. The big study, one of the two big studies is the solution, which will be probably presented at TCT this year. In this study, a sirolimus-coated balloon has been compared to drug-eluting stent in more complex lesion setting as compared to the one of a REC cage-free, hypothesizing the non-inferiority in terms of TVF. This is a sponsorized study by Cortese. And the other big study is our study from my foundation, which is Transform 2. It's comparing another sirolimus-coated balloon to a drug-eluting stent. Again, we are comparing it to drug-eluting stents, and we are hypothesizing the non-inferiority in terms of TLF at 1 year of follow-up. If you want to know more, please join us, sorry for the advertising, at the DEBS meeting, which is the largest DCB dedicated meeting in Europe so far, next February in Rome. So, coming to my conclusion, current generation drug-eluting stents are working extremely well if we are using them in the de novo easy lesion settings. For more complex lesion settings, the performance is lower. Also because in some of these settings, they have not been tested in adequately powered study. We have to remind that. So in the severely calcified lesions, in CTOs, we don't have that important evidence for drug-eluting stents, and their performance in real life is lower. DCB show consistent good results for the small vessel disease setting. with non-inferiority angiographically and clinically on the short term and superiority in this meta-analysis. For larger vessel, we are still awaiting the results of these big trials. Thank you for your attention.
Thanks, Bernardo. Quick question for you. You know, all the trials that are done, you're not enrolled until you do your vessel prep and you have a lesion that's less than 30%. That's obviously an angiographic parameter. Is there a role for routine hemodynamic assessment after vessel prep as a way to really determine if you did an adequate job with vessel prep?
Good question. Actually, of the two big studies, there is a difference. For solution, they randomize patients prior to lesion preparation. In fact, the bailout stenting is higher than for Transform 2. It's around between 15 and 20%. For Transform 2, it's 7%, where we enroll patients after lesion preparation. But coming to your question, we published this year the DCB ARC, where we go into the details of using physiology of imaging to aid when to use DCB or not. Still, I would say it's a foggy realm. So we have a great experience with angiographic parameters. We are suggesting to use imaging or physiology only in selected cases.
So Bernardo, like you guys have a great experience in Europe and been reviewing the subject a lot, but my question now, definitely there is no answer for every question. So the DCB is great. So how do you see the future, as if we're looking about new devices now, factoring in that we're going to have the Magmaris, we're going to have the bioresorbable stent. How do you use hybrid? How do you kind of factor in the DCB stenting together in the future management of the patient? Like, would you see stenting and DCB for certain lesions together?
Yes, of course, we will never get rid of stents. Yeah. I mean, stents are performing very well. We have seen from Wreckage-Free 1 study. So in a prox LED in the left main, in an easy lesion setting, stents are almost perfect. So we will always have stent, but what we would like to avoid is extensive, unnecessary stenting of any dissection that you leave, because now we have DCB. Yeah.
Great. I think it's time to move on. So pleasure to introduce Dr. Kate Kearney from the University of Washington to discuss perfusion balloons.
Okay, thanks everyone. Well, partially I get to talk about this topic because, as Perwaz alluded to earlier, I am a coronary perforator, and that's how we got to test this out as part of the trial. But I want to show a couple of things that we learned along the way, because it is a little bit different from our regular balloons. So, part of the motivation, this went through two different studies for the novel ringer perfusion balloon, which is the one now available in the US, but it's not an entirely new concept, and that's partly because perforations are scary. So while they occur at low percentage, if you look at all-comer PCI, there is a subtle rise with increasing complexity across NCDR, and also we know that they're certainly higher in certain subsets of heavy calcification, as discussed earlier in CTOs. And in those patients who need treatment, actually, across the board at many centers, emergent surgery or mortality is upwards to almost a third of the patients. So we need a strategy to make this uncommon situation that is life-threatening, I think, more manageable, and that's really part of the motivation here. So again, this is not really a new concept by any means. The stack balloon, some of you might still be familiar with. But the ringer balloon, as pictured here, is a different design because it's more like you inflate a guide extension within the vessel. So it can kind of snuggle into the tissue, but it actually creates still a column of flow through there. And so that can be advantageous for improving the flow that we see, which was part of what we looked at this study, and also actually even delivering equipment through there. There is a perfusion balloon available in Japan on the bottom left there that I don't have any experience using. So this study just came out in JSky. Dave Kanzari put together for the perforation experience in 30 patients. This was an emergency exemption of informed consent trial, so it's a little bit different. So it's a small group of patients, and basically largely LS2 or 3 perforations, about half were CTOs and 65% were calcified, not surprisingly. And the ringer balloon was used for main vessel perforations, or could be used to exclude a smaller or perforation where we don't have the wire across by inflating in the main vessel across. And so, simple concept, but just another look at kind of what the design looks like. They really have a narrow window. It's rated burst pressure is 8 and nominal is 6. So it's really the idea is that you're not over expanding it. You have to size that 1-to-1. So I think that is one important key to look at. As not terribly uncommon, this perforation occurred after post-dilating at the transition zone. It was a ADR case. And there's some calcium just distal to the diagonal, but also a big step down in size. And so after post-dilation, I think the balloon was past the diagonal a little bit. So we have some idea of, based off both our IVUS, where the eccentric calcium was, and also where the diag takeoff was, that probably it's going to be just distal to that, because this localizing factor can be difficult. So this puff on the right is to try to land the ringer balloon, because it really doesn't rewrap normally, because it's not a regular balloon. So I think your best inflation is the first one. So I think one caveat is maybe taking an extra second to see if you think you're in the right place. That also can help you identify if you have a good seal, if you do need to go on to place a covered stent, so that we know exactly where that is. I think the hardest part about this is you really have to wait a while. So especially because it doesn't rewrap well, particularly if you're inside a stent that you just placed, you're not going to get as good of a seal if we take it down to take a peek. So this is really, you have to, if the patient's stable, step away from the table, try not to touch anything, just let it do its job. And if we're able to wait that long in the trial, it was about 30 minutes on average. In this particular patient, actually, it looked like we had a pretty good seal, so we take a test shot with the balloon still in place, just in case it's still quite active. We do an echo during this time, check on everything, didn't see any effusion, et cetera. Patient's doing fine, and we're able to seal that. And so I think, in this particular case, it was a CTO. We probably could have gotten away with a regular balloon inflation, given how it started, but we weren't entirely sure where we'd have to land that. And I think that additional perfusion, especially if we were covering the diag, now having flow in the LAD can help her tolerate that better. So that was our rationale there. This was a particularly bad perforation. I think everyone can see that on the left. And kind of one advantage of having that larger inner lumen area of the perfusion balloon is that you can essentially ping pong through that. So there's some difficulty in this case identifying exactly where to place the covered stent. So there was still some leak after the second one. So the perfusion balloon was inflated over that segment that we still see bleeding on the right, and still bleeding despite post-dilation, so kind of the usual things after placing covered stent. And with the 3520 perfusion balloon there, we still see that we're not getting adequate coverage. So this is something that Jay actually has written on, but to help localize where we are, sometimes it's coming from more distal than we think. So this is another one where the views are not actually telling us exactly what the origin of the perforation was. And so while that's helping with the seal, it's not taking care of all of that, so it's not quite as bad as we started. But effectively, we were able to ping pong through that. And you can imagine if we were actually across the perforation well, this gentleman would have had even less bleeding. So that's kind of the idea there that we've used in just a couple of cases so far. In this particular instance, we just took a 308 NC to really identify where the location was, finally confirmed it was more distal, and then placed a third cover stent. And then that's going in there, and finally things look better. So it doesn't solve all of our problems, certainly, but I think the idea is that in particular in patients where the vessel starts open in a large volume territory, whether it's a big dominant right, and maybe they have another CTO in the LAD, that it takes one of those elements off the table. If we can get perfusion and a good seal of that, even if you have to perform a pericardiocentesis, that we can do that without having the additional stress of trying to get MCS in, et cetera. So the idea is just to make this all a little bit more calm. And I think one very telling situation is we actually had a perforation in a live case broadcast, and while that was horrible, we got a lot of messages after that were just sort of how challenging that is for labs that really don't see this very often. We have a CTO volume such that we unfortunately have probably done more than our share, but at the same time, if this is a really rare event, it's a really hard thing to rally your team around and get everything done quickly. You might be the only operator on. These things do happen in STEMI, et cetera, in the middle of the night. So I think the idea is if you could just get it up and control the bleeding and still have perfusion, we can maybe make this better. So it helps buys time. And the one case in particular showed that we could avoid covered stenting in some cases, which hopefully has a better long-term outcome for the patients. and can allow us a different way for ping pong technique in particularly high-risk bleeding purse. One other quick thing just in the CTO space is for reverse cart. It can be used for troubleshooting. So many times for modern day reverse cart, we're bringing a guide extension in antegrade, so you have a different target to get to when you're coming retrograde. And once you make it there, you just get the microcatheter in, you can externalize, et cetera. This is particularly an issue in an unprotected left main because you have to be really sure that we're not coming subintimal past an important branch, but other scenarios as well. So in those cases, if it's challenging to deliver guide extension or we want to be really precise, we found that using the ringer perfusion balloon can be handy there just because it snuggles into the tissue better, so it's harder to get around it. You're going to flop into it more easily. And in this particular gentleman, as soon as we had the left main guide in, he has a lima, so we weren't expecting this to be a problem. He had a ton of chest pain anytime we had the antegrade guide in, which the left main did have disease and was still supplying a diag. So we ended up thinking that that was probably more important there. So what you see on the left image is just the ringer balloon is inflated from the left main across that segment. I wanted to be sure that we re-entered and we're in the same true lumen space so that we weren't going to shut down that diag. So when we stented there, everything is still open, and he fortunately did well. And then I think, downstream, just harken back to the conversation that we just had with Bernardo, that, there are some centers that are interested in looking at a prolonged balloon inflation that you still allow perfusion. You maybe have less thrombus accumulation, et cetera. This was looked at in a Japanese study using this other perfusion balloon. So it's a different design of the balloon, but I think interesting concept that perhaps a very long balloon inflation prevents recoil. And if we get a stent-like result from that, they're coupling that with DCB and considering that. So this is a small study, but I think, something that seems very foreign to us in the US, but is maybe where things are going. So overall, I think revisiting perfusion balloons, it's an old technology dressed up a little bit differently, but the hope is that this can really help with stabilization and management of perforations as an uncommon event in our cath labs, and that prolonged POBA will reduce ischemic burden and reduce the issues with these patients. It's a lot simpler if they're not also having VF or ST elevations while we're managing a perforation. And then in some unique scenarios might help facilitate reverse cart when that's challenging. And I'll stop there. Thank you.
Great, thanks, Kate. A couple questions for you. One is, in your experience and in the publication from Dave, I'm curious how many times when you put the balloon up do you still have bleeding around it?
Yeah, it's a good question. If you haven't placed a stent, we've had pretty good seal because I think you just have more recoil of the tissue as well. And I think that what it's teaching us is that we're not as good at localizing as we thought we were. So, with a regular balloon, we just put it proximally. It's obviously a very quick way to handle that. But sometimes we thought we were also excluding the correct portion, and unless you're kind of moving that around in real time with a shorter balloon, we're not detecting that as much. So really, we only had 1 or 2 cases where we just didn't land it right. But if it's kind of known from a mechanism, the balloon ruptured, we know where that happened, we're covering it there. We've had pretty good luck, even with stents. But I think many of those cases, imaging had been performed, so our sizing was also appropriate. I think if you were way undersized, you probably would run into issues. It's a pretty low radial force, so I think if anything, I would tend to round up, but we'll have to see with more experience.
And have you been able to ever move one forward after it's been inflated?
In the case that came up, we had stented already, so maybe we had enough vessel preparation that was easier. But a very good point is they're not very easy to deliver, and there is a little sizing chart of how that pairs with guide extensions. Because they don't rewrap, you might have to take the guide extension out with it, even if it delivered in, if you don't have a comfortable size metric there. It's a very good point.
So, Kate, I'm so ashamed to say we enrolled 9 out of the 30
Yeah, I think
patients.
you and me were the top enrollers.
So when we did reverse cart and a perf, the balloon was not good enough to, you have to basically finagle it and trying to get the longest you can to it. Even covered stent didn't work good unless you stent from normal to normal for when you did the reverse cart.
Yeah, it's a good point. If you have really big dissection planes feeding into that, that situation, it can often require kind of a long segment of covered stents.
Practical question. So this balloon's obviously not exactly the same as a covered stent, but it's a similar concept. Since it's not a very commonly used product, and exactly to all those us perforators anonymous who've used this balloon, it's not simple to use. And so in an emergency situation, if you're not used to using it, practically speaking, what's your recommendation to an average interventionalist who would you want to use this for a perforation they may have for not a CTO? And how would they be able to use it? Is there a practice model? Is there something that we should be doing to train people to actually use this product? Because the papyrus, that's easy. It goes down really quick.
Mm-hmm.
This is not that simple.
Yeah, I think they both have their issues, right? I mean, when we transitioned to papyrus, we all started losing them, and then we had to learn not to do that, right? So I think everything has a downside. That's very true. The models it is a simple enough device that I think the models give you a pretty good sense of how to use it, and it really is just recognizing where that balloon inflation occurs with the radiopaque markers and getting some anticipation that delivery is going to be more like, it's more akin to maybe a scoring or cutting balloon and not like an easy drug-eluting stent. I would say that's sort of what I go into it thinking. If I could get a Wolverine there, I'm definitely going to be fine. If I could get a winged NC down there, I could probably get the ringer there. But if I'm expecting Takeru or something to message with that, then it's not going to work. I think the models are helpful, and so I think overall for these uncommon scenarios, practicing it at meetings like this when we can get our hands on it is really great.
Just a quick question for the audience. How many people have the ringer balloon in their labs? All right, so clearly not much penetration, so it's good to get some opinion. So thanks so much, Kate, for the highlights. And there's a question over there.
Kate.
Hi, sorry. From like a nursing perspective, because perforations are scary and they don't happen often with us, I'm a Dr. Cortese. What is the anatomy of this balloons? In my head, I was thinking kind of like a true flow where like there's a central and then there's small balloons around that cover where the artery wall would be. Is it like that, or is it kind of like a full balloon that has channels kind of like grooves in it?
Yeah, it's a good question. It's kind of hard to see in those images. So it's basically like, I think of it more like a balloon animal. Like you take one long balloon and then it's just wrapped in a spiral. And so it delivers all attached to the hypotubing and then creates this little inner tube that basically inflates. So I think that is where maybe seeing it in, right in front of you, inflate and deflate is helpful. But it's actually just creating that cylindrical object, but has a little bit of radial force into, like a balloon typically would. But it has that very narrow inflation range because it's basically going to get to that size, and that's about it.
Thank
Does
you.
that answer your question?
Thank you. Again, for many people back there, if you want to go this way, there's a bunch of chairs.
All right, we're going to go ahead and move on. Next is Babar Basir. You got 10 minutes to go through all the new devices. Good luck.
It's going to be quick, don't worry. So thank you so much for having me, especially to Manos, to the whole CVI team. I love CVI conference, how interactive it is, and I think this is a really nice space that we'll be able to have a lot of good discussion about. So I'll get right to it. These are my disclosures. So the most studied device that we have so far available in next generation hemodynamic support devices is the Impella ECP. It's a 9 French catheter that self-expands to about 21 French and provides a little over what a general CP does, so consistently over about 4 liters. It is purpose-built for high-risk PCI. It's not a device that's going to be used in cardiogenic shock. There's a lot of caveats and reasons for that. Both the EFS and the pilot study the pivotal study have been completed. The data is with the FDA who are looking at it, and there will likely be some iterations of how this is commercially utilized. The most important thing to discuss with the ECP is that it's a technology without a wire in place. So it's not a over-the-wire system. And I think that this is something that it takes a little bit of getting used to. And I'll be honest with you, I don't personally like it that much, but it is something that can be done. Typically what happens is because you need an alternative access for your PCI, you put a pigtail catheter which opens up the aortic valve and allows for a pathway for the ECP to be placed. The good thing is that TCT last year, they presented the 30-day data. It was a very good data. The MACE rate was around 6%, less than the benchmark of 24%, with no significant hemolysis and low rates of vascular injury. The next device that I think is really, really promising is the Magenta device. This is a 10 French technology that expands to 30 French, the largest device that we actually have available from that standpoint. It provides mean flows of 5.5 liters and peak flows of 7 to 8 liters of support. It's purpose-built for high-risk PCI and cardiogenic shock. The EFS has been completed. Perwaz was an operator within that, so we can ask him about it. I've only put it in an animal, but it was easy to put in over the wire system. The pivotal trial is underway. It's called the Elevate 3 trial. It's going to enroll 290 patients across just over 30 US-based sites. It's going to be one-to-one randomization with an Impella CP, and they also added ECP, which just shows what they think of their product, that it can be non-inferior even to an Impella ECP. So really, really important technology. You may ask, how does this happen? And the picture actually demonstrates it. The impeller, it's not a rigid plastic. It's very flexible and malleable, which is why it can be crimped onto the pump and then expands within the body. The Supera device is the next iteration of a similar platform to Magenta made by Shifa Medical. It's a 10 French system that expands to about 22 French, similar sizing to the Impella ECP. It provides flows that are between 4 to 5 liters of support, also purpose-built for high-risk PCI and cardiogenic shock. The EFS in the US is still ongoing, but is is near completion, and they raised $120 million for their pivotal trial, so it's going to be started either later this year or next year. They have done over 70 cases, however, in South America with very good outcomes that we're aware of to date, and a very, very, I think, important technology that's coming on the board. The next couple of devices are very equivalent to an Impella CP. So the Cordion Cori P4 system is a 14 French device that typically gets between 3 to 4 liters of support. It is purpose-built for high-risk PCI. In fact, the wire that you use to put the MCS device in its place stays in for the case. The pivotal trial is enrolling. In fact, my colleague Asad Nakhle is the PI in our center for this trial, and he just enrolled his first patient, I think last week or the week before. It has a total enrollment of 280 patients, randomized 1-to-1 with an Impella CP. But you can see here, it's still 14 French. It still gives about the same support as a CP, so it's important to kind of keep these things in mind as they compare to Magenta and Supera, which I think are more promising technologies. The Vitalis system is also very similar to the Impella CP. It's a 14 French device that will have 4 liters of flow. It's purpose-built for high-risk PCI to start. It's had 5 first-in-human cases that have been done. The EFS has started, and the pivotal will be pending as well. However, it has the backing of a very large company such as Boston Scientific, so I think it's going to be important as they roll this out, what iterations are there to be able to improve device positioning and lower hemolysis rate, which is what they're expecting to actually do. I will shift gears and just for 1 minute talk about cardiorenal devices, not because I think they have a whole lot of applicability to you as interventional cardiologists now, but they may in the future. One, because we'll be putting these devices in for our heart failure colleagues the majority of the time, but two, the technology or the way that these devices are being utilized can be a really important pathway for future high-risk PCI and cardiogenic shock devices. And I think there's always a lot of innovators within this meeting. And so really, I challenge you to think about how to utilize the descending aorta to be able to provide enough support to get our patients out of cardiogenic shock. The aortic pump we have the most experience in the US with has an 18 French device that then cinches onto a 6 French drive line, which is technically a little bit challenging to put in. It's cardiorenal device. The EFS trial is done and the pivotal trial is starting. But the most important thing about this technology, it sits in the descending aorta, so size is not as big of an issue. And the other device that is important to talk about is the module heart pump, which is made by Puzzle Medical. This is a typically a 10 French system, though what you're seeing on your screen is a 14 French device, or 14 French sheath. It is essentially a stent that sits in the descending aorta that is retractable and removable at the end of the procedure, and it has individualized pumps which are put into the descending aorta. You can actually put up to 4 pumps there, which each provide around 2 to 2.5 liters of support, and you can argue that you will get flows of 8 to 10 liters of support in the descending aorta. The other thing that they're going to be doing with this device is that they're going to be able to snare it out of an 8 to 10 French axillary artery placement as well, which will allow for ambulation and things like that. So again, this is what's on the horizon, not necessarily high-risk PCI or cardiogenic shock, but you can see the applicability for this in the future. So I stayed on time. I gave you a brief glimpse into what is available, but you have an amazing panel who I think can delve into a little bit more details. The bottom line, though, is this is a really, really exciting time for us, right? We've made a lot of strides in high-risk PCI. We're going to have the BESIS 3 trial as well as the PROTECT 4 trial, which are both completed, presented within the next year. You have new technologies that are available that are smaller and more powerful, and this comes on the brink of a year plus of post-danger work that we've done in cardiogenic shock, where we can now develop the system of care needed to treat patients in cardiogenic shock. So lots of innovation within this space, and I think it's a really exciting time to be an interventional cardiologist. Thank you.
All right, well done. So I guess I'll start it off. You don't like using ECP. Why?
It's not that I don't like using ECP. I think ECP, the important thing is that you're putting it in a controlled environment. You have to have the pigtail in place to place it. We've done it without the pigtail as well. But you are sitting there knocking up against the aortic valve a bunch of times. There's always a chance that you're going to have some shower embolism that occurs. We didn't see it within the trial. I think generally speaking, I'm pretty comfortable with it. But maybe I'm a little conservative. I just like the wire.
I have a question. So, Babar, the biggest problem with all these devices, whether it's for high-risk PCI or cardiogenic shock, is the hemolysis.
Sure.
I mean, we all do these beautiful procedures and leave it in, and 2 hours later, oh, the patient's urine is disgusting. You need to change. So how have any of these devices solved that problem?
Yeah, I think it actually gets into an important concept, which is that the major thing with all of these devices is that I've always projected them to you in a naturally positive direction, right? But the thing is, we don't know about the durability of these devices, and we don't know generally about the complications of these devices outside of a few hour window. The thing about hemolysis that's important to remember is that hemolysis is directly related to the size of the impeller. And so particularly with magenta and supera, where you have the larger surface area for the impeller itself, it becomes important that theoretically you should get less hemolysis. Now, if you look at any of the trials that have been done so far in the EFS studies, the hemolysis rates have been very, very low. So that's promising, but I totally agree we need more data going forward to be able to make that decision.
Well, I would agree that the impeller size is a big determinant from what we know now of hemolysis. But I think the fact that you're now pumping it through a cannula that is collapsing and can be affected by position, by the aortic valve, et cetera, may not be the pump size may not be, or impeller size may not be the only determinant of hemolysis, and I think that's potentially going to be a big issue with a lot of these expandable devices going forward. We didn't see it with ECP in the trial, but I'm certainly curious about that with supera and with magenta coming out.
And Jason, to your point, though, the other thing about the newer pumps is that so magenta and supera are put deep into the left into the ventricular apex. So whether that induces arrhythmias and interactions that cause hemolysis, we don't know yet, right? In the high-risk PCI space, you're very forgiving in a few hours, but the longevity of a cardiogenic shock patient it becomes scary to see what happens. So.
The other thing that I'm real curious about too is the difference between the devices. The big change from ECP to CP to ECP for us was that the impeller went in the ventricle as opposed to outside the ventricle. Supera, it's outside the ventricle. Magenta, it's inside the ventricle. Is there going to be a difference in these devices based on that? Be a fascinating thing to see what happens with this.
Yeah, but for high-risk PCI and short-term permanence of these devices, we don't have to forget that the problem is the bleeding and the limb ischemia. So we have, so this is very important. So at our institution, we developed a multidisciplinary approach to these patients for patient selection, assessment of the periphery with CT scan, because if you do it, whatever you do before, it's a huge investment on our patients. So I think this is a key point. Nothing related to your excellent presentation on the future, but I can perceive that also in the future, the whole will be a big one.
Yeah, I think the key is you're balancing high-risk PCI short-term events, which, as Barbara is saying, are honestly low today. If you really look at it, if you think about it, the biggest one we have is access site complications, right? For short-term use in PCI. I think the smaller the device you go in, common sense will dictate the fewer vascular complications you'll have in the short term. The real question becomes is now taking this into the next leap, which is what I think most of us who take care of shock patients and really sick patients, the question is now, okay, so you decrease vascular complications. That's going to happen with a decreased access size, most likely. I mean, the odds are not that that's not going to happen. It will happen. The question now becomes is durability, flow, and what are you really gaining for the patient? Are you able to actually treat the patient acutely, especially in a reversible condition like AMI shock, where you could actively reverse them very quickly? Can you treat them and get them out of trouble? Very different than a heart failure, chronic dilated LV shock, in which that patient's a very different presentation, and that may be a much longer, much more durable, weeks to months implantation like we see with Impella 5.5 surgically right now. So I think these patient populations are very different, and and that's why they're looking at them iteratively. And I think first step, high-risk PCI, very easy. I think the next step is going to be much harder, and we'll have to see how that works out.
Yeah, Bob, to extend on Perwaz's comments, really looking at the future, I think one of our goals in shock is to think about how we're going to have a percutaneous device that's going to equate, for example, what the Impella 5.5 is doing, both in its ability to sit in the percutaneous axillary space and then actually have an extended period. Are you aware of any devices that are going to be optimized for this, where you're looking at 2 to 4 weeks and allow ambulation and deliver 5 liters instead of the 3 that we might be with?
Yeah, so it's a great point. I think the only thing that we've actually gotten is the 5 liters. When you talk about anything else, these are not purpose-built axillary devices. We were talking about it in the heart failure meeting earlier this morning. There probably will be bridges to more intermediate surgical devices as of right now. Now, you can probably get most patients out of shock with the 5-liter device within the first few days for at least STEMI and AMI cardiogenic shock. But the heart failure cardiogenic shock space, where we need longer durations of therapies, I don't think that we have any data or any information that these devices will fit that role.
And Barbara, one more thing. I think as we are using these devices for a platform for shock, just like what Impella initially came to the market, is the LV geometry and the size. Back to Perwaz's comment is that in dilated or the ones that they started remodeling, these devices are becoming a little bit more forgiving. But in acute or AMI shock, I think still we have a lot of problem. And the other comment is about the washout from the ascending aorta. That's a problem with majority of devices. And these are the lessons that we learned from the LVAD era, how it came to the market, and we started learning about it.
Great, thanks, Robert. We're going to go ahead and move on just for time. We could probably talk about this for another hour. Next up is Jay Khatri, here to talk about new CTO devices.
Okay, great, thank you. All right, well, thank you again for the invitation to speak. So I will go through what I think are the most exciting things in development for CTO PCI. So integrated wiring remains the predominant tool for crossing any corneal lesion and an CTO lesion as well. There remains regional preferences in terms of how best to achieve this, and this has to do with device availability, philosophy, whatnot. It's sort of irrelevant, but there are a bunch of different ways to cross a CTO integratedly and either cross true to true or perform some sort of a reentry. And so the wire-based methods can be enhanced. There are some pretty interesting things that I've seen recently, which we'll go over, involving using fluoroscopy to better understand exactly how to navigate with the wire, as well as using intravascular imaging to enhance how to navigate with a wire. So we'll go through some of that. And then finally, we'll talk about some iterations about reentry. We all are familiar with Stingray, which is sort of the mainstay of reentry currently, at least in the United States. But there are some advances that are going to change that field as well. So we'll go through some of that. This paper is really scary, but I think this is important to share with you all. This is from Eugene Wu and the Asia Pacific CTO group. So there was a description from Japan about this concept called 3D wiring, where they can use multiple orthogonal views to recreate a three-dimensional model of how to navigate a coronary artery. Eugene kind of simplified this a little bit, and I think this is worth spending a little bit of time to talk about. So basically, you take two orthogonal views, and what you'll see is that the wire is either near the target or far from the target, and I'm referring specifically to the shaft of the wire. And so he takes the ratio of the near versus the far, and that determines how much to rotate the wire. It's simple trigonometry, and we've all done this where it looks perfect in one view and it looks really weird in another view, and then you over-rotate, and then it looks weird in one view and perfect in the other view. What Eugene is saying is that the reason this is happening is because of parallax, and what you need to understand is that the adjustments need to be very, very subtle, and it's really based on trigonometry and the ratio of where the shaft is near and where the shaft is far. And I'm not going to spend too much time talking about this, but basically it requires very minute adjustments in one view versus the other view to target the lesion. So he advocates to start 10 to 15 millimeters proximal to the distal cap, go into these orthogonal views, use this basic trigonometry to understand how to make the adjustments, and he's actually even developed a specific torquer tool to make these very, very fine adjustments. So very interesting. I practice this on ISR CTOs, which I think is a great way to kind of understand these concepts, but it's pretty fascinating how precise you can be. And they're also developing a dedicated 15-gram wire, so obviously you need something very sharp and very stiff, and also torque responsive to make it work. So that's also under development, so stay tuned to see how that goes. Slightly different, but sort of the same concept is Dr. Kato and his colleagues in Japan. They've proposed another idea altogether, and that's identifying the optimal views that are orthogonal. So there's the penetration view where you're on phos with the artery. So if you look in the upper left panel, the wire's right on top of the artery. The question is the wire tip pointing out of the screen or into the screen? And so then you have to go to the orthogonal view to understand if you're pointing away from the artery or towards the artery. And so, according to Dr. Kato, you just need to make the appropriate 90-degree rotations in orthogonal views to understand which way you need to orient the wire. And the challenge here is, like, how do you determine what these views are? I mean, conceptually, areocranial, eleocranial for an LAD, LAO-REO for RCA, eleocranial, eleocaudal for a distal right, those make sense. But the problem is the arteries are three-dimensional, and you can't always use those views to achieve this. So Dr. Kato and his group, as well as Asahi, have developed software that will use any random orthogonal planes that you take, and they segment the artery out and determine the vector of your distal target. And so from that, the computer can spit out the proposed orthogonal views that will actually work to do this. So they're often quite counterintuitive to what you would think, and there are several nice cases that were presented at CTO Plus describing this concept where the views that you would think would be orthogonal are nothing like the views that are required, and that's based on the vessel vector. And there's some software that Asahi has developed to predict these, and it also accounts for what the C-arm is able to achieve. So this is another idea of how you could potentially achieve reentry using fluoroscopy. So moving on from that, so let's say you're not going to do fluoroscopy. There are some imaging modalities that are pretty exciting as well. So this is a paper that Pratik Sandasara from Emory published using a novel catheter that uses OCT guidance to redirect guide wires for penetration. So I'll just show you this fluorosave of Pratik rotating this catheter based on OCT guidance. which to me it seems a little counterintuitive because we're subintimal and you need to flush with OCT to clear the blood, and do you really want to be flushing in a subintimal plane? But this is an interesting case where they did show this, so stay tuned to see where this device is in terms of development. This is something that is a little bit easier to understand. This is a paper from my friend Alex Avran in France, where Alex is a world expert in using the recross microcatheter for reentry. And so what Alex does now is if he's unable to reenter and he remains subintimal, he'll just dilate the subintimal space, put an IVUS in the subintimal plane, and use that for real-time IVUS guidance. And this comes from a concept that was really described from researchers in Japan. They have a dedicated ultra-low profile pullback IVUS catheter that Terumo sells in Japan for this idea altogether. And so Alex just sort of has adapted this to the recross catheter. It does require 8 French catheter to do this. You got to be comfortable with dilating the subintimal space to do it, but it can be done for real-time guidance of reentry. We've actually done this ourselves, so this is an idea that I got from the Japanese as well. But in the U.S. at least, we do a lot of investment procedures. It's a case where we did antegrade, retrograde, ADR, nothing worked. We're about to do an investment, so I figured if we're going to do an investment and dilate this anyways, why not let's just put the IVUS in there and see what we can see. And so I'll play on the right panel. So this is the IVUS in the subintimal plane. And then we have a penetration wire and a microcatheter next to it. And we're just playing with the wire to understand if we can figure out where the tip is going. And actually, it's not that hard to do this. So this is the actual IVUS from the case where we were able to re-enter the true lumen without a lot of difficulty, just using the IVUS for real-time guidance. So these are concepts that, have been described in the literature, and in reality, you can do this with tools that are already available on the shelf currently. So that's the puncture right there. So getting to where are we going with this? So Cal has a device that's under development, and Cal can fill us in on this. So it's an actual microcatheter with an integrated IVUS, which you can use the IVUS to reorient the exit port of the microcatheter to perform that reentry, kind of like what I showed you, but it's all one piece instead of 2 pieces. Instead of a separate microcatheter and IVUS, it's just one device that can do both things. So that's something that I'll be looking very forward to using at some point in the near future. And then perhaps the device that we're all anticipating is Bill Nicholson's Triumph microcatheter. So this device is designed to basically deal with all of the shortcomings of Stingray. So it's designed to be able to navigate through tortuosity and calcium. It's designed to be able to deal with the hematoma because you can connect this to a TUI and a suction system to aspirate the hematoma. It has multiple guide wire exit ports, so you don't really need to orient this device. You can just poke through all the holes until you re-enter. So it's a pretty elegant solution to a lot of the shortcomings of Stingray. So this is a case of Bill's that I was going to share with you guys. So on the left panel is an animal model where they show the hematoma being evacuated with a suction. Obviously, as you evacuate the hematoma, the target becomes bigger. And then in the center panel, you'll see the Triumph catheter in a human RCA. After aspiration, you can see the target is screened left of the microcatheter. And then the right panel, you'll see them do a reentry. So a pretty amazing and exciting device that also will be very, very exciting to get our hands on. So in conclusion, I would say antegrade wiring remains the mainstay of CTO PCI. There are a lot of novel concepts about how best to navigate through the CTO segment, how to navigate the vessel, how to do reentry just using fluoroscopy alone. And there are some advances in terms of ADR, so beyond Stingray. So there are some really exciting image enhancement tools to perform reentry as well as catheter-based reentry tools. So stay tuned. I think this is a really exciting time for CTO PCI.
Again, any questions from the audience, please raise your hand and I'll come over and give you the microphone.
Jay, great. Thank you so much for the great overview. I'm happy to start off. I think this is showing us that we're underusing our ability to use X-ray. Like we're just used to looking in 2D as a projection technique and really not understanding this. A lot of this came from Japan because they have biplane fluoroscopy as very much as part of that. So we definitely need kind of advanced software tools to make this easy for us to kind of tell us more actively how to direct. But as you look at this, as you're in favor of this, how do you kind of reconcile, for example, stiff wire use, perforation risk, as opposed to going to more classic, safer knuckle polymer-jacketed dissection planes where you might do classic reentry?
Yeah, I mean, that gets to that, this sort of divide between North America and the rest of the world, right? So we have sort of a predilection towards knuckling, considering that to be safer, the subintimal space, trust to knuckle. These concepts are not necessarily exclusive of the stuff that I showed you. So, I'm a big advocate of polymer jacketed wires defining the path of least resistance. And if it finds a lumen, great. If it doesn't, that's fine too. Because then I have a guardrail in place for penetration wires, more aggressive wires. And these concepts that I'm talking about are sort of building on this whole idea of parallel wiring, but taking it to a much higher level using additional information you get from either fluoroscopy or from imaging to be much more safe with an aggressive wire. But yes, your point's well taken that if this is done casually, it can be quite dangerous.
Cal, this was great. I didn't know about your catheter. That's really exciting, and that's great, Jay, that you could share that. Can you comment about like the size of that and the kind of the technical aspects of really integrating those two, and perhaps the ultrasound frequency of transducer as well? That'd be great.
Yeah, absolutely. So the IVUS guided, the problem with using the IVUS nowadays, it's a microcatheter in the IVUS. You can see the true lumen with the IVUS. The microcatheter sits somewhere in the subintimal space, and you cannot really direct the wire. And I don't know if you guys, anybody does peripheral vascular intervention. We have a device that's called Pioneer, where basically you turn it until you see the true lumen in 12 o'clock, and you use Doppler, color Doppler. And you literally plunge a needle, and through the needle you put a wire. The problem with that device is too bulky. It's based on a Volcano IVUS, and it has 64 crystals, and it has a chip inside it, and you cannot deliver it in the coronary artery. You need 8 French guide to deliver it anywhere, or sometimes 8 French sheath. So I actually, I tried to use it, and I used it successfully in one left circumflex CTO, and I was able to do it. And then the idea came, okay, well, we need to do it in the coronary. So what we did, we designed a catheter where basically there is an IVUS just in kind of one direction IVUS, not 360, but also there is a port goes in the same direction with the IVUS. So you turn the catheter until you see the true lumen, and if you advance any wire, the wire is going to go toward the lumen. And that actually will solve the problem we are facing in the cath lab using IVUS guidance. Like all these mathematical equations and everything, basically the solution is simple and stupid. You just have to kind of have the device point it. So we achieved 4.1 French catheter size, and we achieved 1-to-1. And we have a team working on it, and we are actually hopefully going to be doing the cadaver work or animal work soon.
Non-rotational? It's a solid state.
Yeah, so the rotational, you need the shaft that actually rotate the IVUS, which is going to add about 1.2 French, so it's become 5 French. The Aculite device is 4 French and 4.1 French, so is our device. It's a phased array. Like we demonstrated in a bench model like that you need only 1 crystal of IVUS, like the IVUS sensor, and with no processing and everything, you can see really excellent lumen. Hopefully we'll be able to present more imaging next meeting. Probably we're going to be submitting to the FDA.
Excellent. Any other questions from the audience or panel? Good. All right, we're going to go ahead and jump to our last talk. It's going to be Devices for Balloon Uncrossable Lesions by Dr. Timir Paul. Welcome.
Thank you, CVI team and Dr. Bilakis for inviting me. It is a pleasure to be here today. I will show you a few cases for balloon uncrossable lesion in non-CTO settings. I have no disclosures. So what is balloon uncrossable lesion? Wire crossed but balloon didn't cross. It's not only the balloon, but microcatheter didn't cross either. So it's a kind of misnomer, but both. It's one of the most frustrating situations for interventional cardiologists, and it is often due to moderate to severe calcified lesions or tortuosity, or maybe both. So we'll show a case, 83-year-old male transferred from outside hospital for non-STEMI, and he had CABES 1998, 3 vessels. You can see all these labs, vitals, and troponin was elevated, of course. His last echo was LVEF 40 to 45% with severe inferior hypokinesis. So this is the initial angiogram. You can see the left circumflex is mild to moderate disease, LADF severe disease, and RCA is proximally occluded. Lima to LAD is widely open, and then vein graft to RCA is completely occluded. And you can see the last 2 slides, 2 images, that vein graft to diagonal is a hazy lesion in mid to distal, pretty much distal, in the 2 orthogonal views, around 90%, I thought. So what would you do? I thought that, okay, this is non-STEMI, hazy lesion, thrombotic lesion, so it would be relatively easier case for me. So I started simple technique, like I used the LCB guide. I tried to cross the lesion with the run-through wire, and then tried with the cyan blue, didn't work. I couldn't cross even the lesion. So then I used the microcatheter, used the whisper wire, couldn't cross the lesion. And you can see here, while I was trying to cross all of this lesion, there is no reflow now. So very bad situation. Then I changed the guide to AL1, and then I again used this microcatheter. Finally, I was able to cross the lesion with the pilot 50. So although I crossed the lesion, and you can see there's completely no reflow. So what is the challenges here? Multiple I tried the Corsair Pro microcatheter. Finally, I crossed the lesion, but no reflow. So that's one problem. Second problem is after crossing the wire, I tried to cross the Corsair Pro XS microcatheter. Didn't go. I used the guideliners, then again tried with the Corsair XS microcatheter, didn't cross. Tried Turnpike LP microcatheter, I was not successful to cross. So let me ask with the expert panel here, what do you do now? I mean, of course, there will be multiple approaches. I'll show what I did, but you are the expert operator, so.
To open the native.
That's another situation. If you can open the native scheme, is non-STEMI. So now I'm in the middle of the case.
So there are 2 devices I use in this situation. Nowadays, before I do all this, I immediately remove the wire and cross primarily with a rotor wire, and or there are Turnpike Gold. It's actually it screws into the more literally it's like a screw on the tip, and it's a metal, so it screws in and kind of modifies the plaque a little bit for you, so you can cross back with the balloon.
Right. So those are the good suggestions. You can try Tornus, or you can try the Turnpike Gold, that is screw that is modified the plug and goes. So now what I did, I used 1.0 sapphire balloon. Finally, I was able to cross there, and I used the high pressure, and I ruptured the balloon, called granuloplasty or microdissection. As soon as I ruptured the balloon, you can see the TIMI3 flow reestablished, and still there is a signified, like calcified lesion, 99% lesion there. I thought it would be easier case, but it's not. So now, after this sapphire balloon crossed, and then I did some serial balloon dilatation, it became relatively easy, like a routine PCI, IVAS, and you can see here that even with the multiple serial balloon dilatation, there is a lot of still residual calcium there. And this is the IVAS run, a severely calcified lesion, very tight, And then the distal reference vessel and proximal reference vessel almost 3.5, 3.6. So I used the shock wave at this point, 3.5 by 12, and shock delivered during the second shock balloon rupture. So then I used the new one after a couple of cycles. Then I used the non-compliant balloon, make sure then 2 orthogonal views is all good expansion. And then you can see here the good expansion there. And then, of course, the 3.5 stent, post-dilatation, and with good results. And you can see here the final results there. So what is the challenges are the guide. So I used from LCB guide to L1 guide, crossed with the stiffer wire. Guideliner was used. The lowest profile balloon we used under granuloplasty helped. And then I also changed that pilot 52 wiggle wire before we do serial balloon dilatation, and then just routine PCI. We'll show another case. A 67-year-old female presents to the ER with shortness of breath and chest pain, and found to have as very elevated elevated troponin, non-STEMI, LBF is 40 to 45%, and some primary mild hypertension. So this is the initial diagnostic. As you can see, the prox to mid RCA is severely calcified lesion, very tortuous, and proximal also tortuous anatomy. So I crossed the wire. I tried with the run-through, didn't cross, but I was able to cross with the whisper. Then, in this case, I tried to cross with the fine cross. Couldn't cross. Then I tried 1.2 threaded balloon, wouldn't cross. So because of severely calcified lesion, I need to do some kind of atherectomy here. You can do laser, but I decided to do the orbital atherectomy. And because of significant initial bend, so because of that, I need to extend the wire, workhorse wire to Viper wire, if you want to do the orbital atherectomy, unless in this case you want to do laser atherectomy. So I'll show you. So this is the, again, I use the AL1 guide to better support with side holes because there are some osteal lesion and smaller size vessel. What I did here, you can see that I put the that orbital atherectomy device, the cone, into the lesion, and then I take out the whisper, and then I was able to put the Viper wire with some manipulation. But and after that, when you use that, so it's the temporary pacemaker before that. So then I did the atherectomy, and then just one balloon dilatation, then IVS, and then put the appropriately sized balloon and stent and post dilatation. And you can see here that after the atherectomy and then some balloon dilatation, this balloon expanded there. There is another lesion distally, so we did the balloons, and then this is the final results. So all this, in this case, we again use the stronger support, AL1 guide, orbital atherectomy, nose cone wedged into the lesion, and extends the whisper wire with the advanced flex tip wire. The same technique you can try. I didn't try in this case, but some microcatheter nose cone you can put in the lesion and try to extend the atherectomy wire. And then once you extend the atherectomy wire, it's probably easy to do atherectomy. If nothing cross, then the other option is just laser at that point. So for some teaching points and learning points that you have to improve your support, like guide support, you can use the larger guide catheter, 7.8 French, more supportive shape like AL1 for RCA, deep engagement of the guide. Most of the time, guide catheter extension is very helpful. Wires, you can use the anchor wire, body wire technique, or also can use the more supportive wire like a wiggle wire that I used. Anchor balloon is another way to get more support. And at some point, I'm sure everybody did this anchor balloon technique. Just an example here. Then you have to do, of course, plaque modification, right? So for plaque modification, it's smaller balloons. It's a simple technique. We have now a lot of smaller balloons, semi-compliant balloon, threaded balloon, and sapphire balloon. Do the granuloplasty, like a balloon-assisted microdissection. And a small balloon, you can try to use the smaller balloon ways, the back and forth movement, and that sometimes goes in. A lot of microcatheter, as Dr. Khaldoon Alaswad mentioned, that the turnpike gold and especially designed for plaque modification screw, it can go. there are different types of smaller other catheters, true microcatheter you can see here. Wire cutting technique or multi-plaque crushing technique also you can use, laser atherectomy, and of course the finally rotational orbital atherectomy. There are some CTO, it's not a CTO case, but there are some different CTO techniques. There are extra approach that you can use for balloon uncrossable lesion that I didn't mention here. One is this balloon assisted microdissection. That's the way it works. And this is the proposed algorithm by Dr. Bilakis. I just modified a little bit without color coding, that his slides from his book was color coded. So try first line of approach is small balloon, then you rupture the balloon for granuloplasty, then you can use the increased support with guide catheter and wire or balloon, then try the microcatheter wire technique, of course the laser and atherectomy at the end, and then some extra CTO technique. But I think that you don't have to use, this is not the exact approach that you have to use. I think the first step should be always the good guide catheter support, good wires, and support is the most important. Then try all of this that I did. Laser atherectomy has their own risk. Of course, all the expensive devices too. So you can start with a simple device, and this is the algorithm. And he also, Dr. Bilak is also co-authored this one of the paper, and then also mentioned in a different way, but pretty much the same thing, that first line, second line, and third line techniques. So for take-home message, that balloon uncrossable lesion, we optimize the guide support, increase the support first, try to low profile balloon assisted microdissection. Then if it doesn't work, try to some microcatheter that is specifically designed to plaque modification. If it doesn't work, if you cross the wire, that of course laser would be an option. For my case, no reflow, laser would be an option there too, but for atherectomy, if you have no reflow, and in some other cases, you probably would not be able to do the atherectomy. Then that I show you where's the orbital atherectomy catheter nose cone or microcatheter nose cone technique, and to exchange the atherectomy wires with the workhorse wire that would work. Most of the time, it's like a hybrid approach. There is no that one approach would work for everything, and these techniques are interchangeable and should be used at your experience, your operator, and what you have in your labs. Thank you for your attention. Any questions?
There is one technique I use frequently, Timir, in the cath lab. It's actually the Takiro balloon. The good thing about it, the sapphire balloon for granuloplasty, and I use granuloplasty every time, and every time it doesn't work. So it always comes back after that with the Takiro balloon. The good thing about Takiro balloon, 1.5 millimeter, you actually can inflate it to 20 atmospheres and it doesn't rupture. You can go even to higher, and what happens is kind of pries it open. You inflate it, you push really hard, you inflate it, you deflate it, you push again, and you inflate again, and you push again, and you inflate again, and that's work. But that's all contingent on having a good guide support. If you don't have a good guide support, nothing will work.
Great. Anybody on the panel have experience with the Javelin from Shockwave?
I did. I used the peripheral Javelin in the coronary. I'm not sure, like 3 times, the 3 times didn't work really yet, but I think there will be a room when they come with a coronary, it will be easier to deliver and probably will work. Still, you're gonna have to put it to test.
Yeah, so the Javelin essentially is a sound wave emitting device that has the emitter right at the tip, and it's used kind of like you would use a microcatheter, but at the tip of it you've got the shockwave emitter that is the idea is that it's going to be kind of a forward treating device. Certainly something that we're all kind of interested in, and again we'll have to figure out where it fits in the algorithm. The last thing I would say is that for those of you that don't have a lot of experience with balloon uncrossable lesions, I would say that 90+% of these problems are managed with a guide extension. Oftentimes that's delivered all the way down to the lesion and changing to a different microcatheter. So sometimes it's going from a larger microcatheter to a smaller microcatheter, or to a different microcatheter that has different tip properties, like Turnpike Gold or a Mamba Flex that is a little different than the other microcatheters. The vast majority of the time, you're going to solve the problem with those two things. But having these other things that are in the toolbox, like granuloplasty, small balloons, progressive dilatation, anchor balloons, doing an external guideline or trap with a second guide, those things come into play very, very rarely. But it's nice to have those in your toolbox that if you ever get to the point where you need to, it can be helpful. The challenge with going to rotational atherectomy or orbital atherectomy is that at some point it requires a little bit of faith that when you pull your wire, you're going to be able to rewire with one of those other devices. The nice thing about laser is that you don't have to remove your device or remove your wire. You just obviously don't want to laser over a jacketed wire and melt the jacket. So, but you kind of hit the vast majority of those things in your talks, which was fantastic. So, thanks everybody for hanging in there on this session. This was really fun to kind of see some of the new things coming out. Hope you got something out of it, and certainly hit us up if you have any questions.